It's the first time in history that a family of molecules has achieved weight loss results similar to surgery.
Today, there is a drug that can help you change your life, to extend your life by several years.
They protect the heart and kidneys, reduce cravings for alcohol and food, all at the same time and with a very favorable side effect profile.
If we have fewer obese people, we will have fewer hospitalizations, less need for intensive care, and less need for expensive treatments.
But the real challenge, both as users and as professionals, is learning to use these tools properly.
And if you take the drug and end up in intensive care because of a toxic reaction,
there's no antidote for these things.
There were very few cases where we were successful in discontinuing the drug.
Today we are joined by a great expert on these drugs, Dr. Duré.
Unfortunately, obesity is a very cruel disease.
In today's episode, you will learn to distinguish between legal peptides and others that pose a real threat to your health. You will learn how to use obesity treatment to maximize its results, and above all, you will discover which red lines you should never cross. Welcome to Better Than Yesterday, Dr. Duré. Well, Christian, welcome to Better Than Yesterday. How are you? Good.
Thank you very much. I'm doing well now that it's hot in Malaga. It was quite cold in Sweden.
Cool, right? No.
Yes. So it's a joy to have a bit of sun at least.
Great, Christian. You've been in Sweden for over 10 years, working as a doctor, researching sepsis, right? At the Karolinska. And how do you balance this? Or how did you end up coming from that background, treating patients with obesity on a daily basis with GLP-1 treatments, among other things?
Well, actually, I'm an emergency physician, and I also work in intermediate care in a hospital that's quite centrally located in Stockholm. And also, as you said, I work with sepsis in sepsis research, and it really caught my attention. Treatment with these GLP-1 agonists. Because, well, sepsis, everyone knows what sepsis is. Sepsis is the systemic inflammatory response that leads to organ dysfunction, to multi-system involvement, right? Sorry for my Spanish. I mainly work in English and Swedish.
Don't worry, you already forgot Spanish. No.
Well, yes, a little. Besides, I have the Chaco Spanish, from Argentina, but in the emergency room, in the ICU, I realized that there are many obese people. And when you start reading, you realize that this obesity is not just an excess or an aesthetic problem, but rather, a chronic inflammation. No, it's low grade, which damages the vascular endothelium and the organs. And I had many patients that we admitted to intensive care, whose complications I see precisely because of obesity. And when I saw that many patients improved with these treatments, and about the treatment, it really caught my attention. And once I started working with a company that does a great job, and once I see how my patients improve their lifestyle, their quality of life, and have fewer emergency or intensive care interventions, yes. So then I said, and fewer infections, less inflammation. I said, this is something that really catches my attention, and I started working a lot with this.
Of course, because it might seem like these are two very distant points, and they are: intensive care, ICU, sepsis, and obesity, an outpatient with a chronic condition. But in the end, you see the patient with obesity when their life is really in danger, and that's when you truly realize what a huge risk factor obesity is, right? But we all remember the excess morbidity and mortality that patients had, for example, during COVID with respiratory infections, when obesity was present. No, and many of those who were admitted, my colleagues in intensive care would tell me, out of those who were admitted today, 80% have obesity. So that's when we realized the risk, right, that obesity poses for the population.
Let's keep this in mind. Myocardial infarction. Who are most patients with myocardial infarction? Adults, obese, hypertensive, diabetic. So the majority, right? Of course. But I'm talking about chronic inflammations, chronic pain. I mean, people who have knee pain. Who are they? Obese people, people with hypertension, diabetics. So unfortunately, obesity is, on top of that, a very cruel disease, right? Because it works little by little and little by little and little by little. You start being obese from a young age, from childhood into adulthood. And this kind of intensive care admissions, or these patients with an acute respiratory problem, for example, they don't present this way from the start, but rather they are those who have been obese for a long time, of course. And then they end up coming to us in the emergency room or in intensive care when that obesity, as we say in Argentina, takes its toll, right?
Of course. Anyway, very interesting.
No, it's very interesting. And being able to treat it early, to prevent my patient from ending up in intensive care is one of the most gratifying things.
I can imagine.
Exactly, of course.
Well, let's start by analyzing a bit of this whole therapeutic arsenal so that anyone listening, maybe for the first time or without much background in it, can understand what these things are and what they're for, right? So, I don't know if you want to give us a bit of background on what GLP-1 receptor agonists are. I'll just say GLP-1 to make the conversation flow more smoothly, right? How were they discovered? What do they do in the body? Where are they produced? Just a bit in simple terms so that people, our specialist providers, know what we're talking about.
Well, this is a peptide hormone that exists in our body. It's produced in the intestine, in the small intestine, in the ileum, and in the colon, right? But it's also produced in the brain, in the brainstem, and it gets activated when you eat any type of food. That is, when nutrients enter the body, it gets activated. What they do is activate your intestines and stimulate the production of, what the liver and pancreas produce, so we can digest our food and produce things like glucagon and insulin, right?
Great.
So, for our gut and our brain to be connected, and for the brain to say, well, I'm full, I've eaten enough, or no, I'm not full, we need to keep eating.
Of course, it regulates the mechanisms of hunger and satiety a bit, right?
Exactly. It regulates the mechanisms of hunger and satiety, and it exists in our body. That's what happens. After that, you have to understand how they work. Because even though those hormones exist in our body, there are also enzymes that break them down, and sometimes those hormones have a very short lifespan, right? So they are eliminated very quickly.
Okay, to recap, it promotes insulin secretion, right? It's always glucose dependent. That is, if we give GLP-1 to a person and they haven't eaten glucose, it doesn't cause hypoglycemia. Only if they eat carbohydrates, if they eat glucose, that's when that person's insulin sensitivity improves. It delays gastric emptying, right? So it creates a strong feeling of fullness in the gut, but also in the brain, right? It creates central satiety at the level of the hypothalamic receptor. I mean, it creates satiety through different pathways, pressing different buttons, right? Those are the main metabolic effects we prescribe them for, right? They also have many others.
Yes, of course. Well, and a person who receives these GLP-1 analogs, it kind of slows down gastric movement and intestinal movement.
And do you know the story of how the first molecule, the first GLP-1, was discovered from the Gila monster?
No, how?
Well, this is about a researcher who was studying the behavior of the Gila monster, which is a small lizard that lives in the deserts of Mexico and Baja California. And this lizard has the peculiarity that it can eat up to 3 or 4 times a year. I mean, it can only eat 3 or 4 times a year. I mean, just imagine how satiated it stays. So, it could be that in the saliva of this lizard, there's something that induces satiety. And from there, exenatide came about, which was the first GLP-1 to be marketed, right? Quite some time ago, I mean, from the Gila monster.
Yes, I have the researcher's name written down. David, yes.
Daniel Trucker?
Exactly.
Daniel Trucker, exactly.
Daniel Trucker, yes.
Okay, great. Well, basically people understand it. It's a key molecule in our metabolism that is also lost in different pathological conditions. For example, in obesity, we have less GLP-1. In type 2 diabetes, we have less GLP-1. In inflammatory states, we have less GLP-1. And now, a series of molecules are being designed with varying durations, different names, commercial forms, which we generally call GLP-1. GLP can be injected or taken orally, and let's say it restores those levels. Okay, up to this point, I've understood everything. Now then, you know that in recent years, for almost a decade now, the growth of all these drugs has been crazy, right?
And also how widespread they've become in society, right? Something that was unknown before.
I think everyone knows about these obesity and weight loss drugs now, right? So, what would you say to that family member, friend, neighbor, or partner who's going to say to you, but Christian, Dr. Christian, look, I have a wedding and I need to lose 3 or 4 kilos because this isn't it. I can't lose it by exercising or eating well. I need these drugs. What would you say to this kind of person?
There are a lot of myths surrounding these drugs all over the world. Well, now I also need to lose weight, and I would love to lose 3 or 4 kilos for a wedding I actually have in a month in Nashville that I'm going to attend. Wish me luck. Let's start with what's important, Dr. Borja Bandera, and what people need to understand, that this is not a cosmetic treatment. or it shouldn't be. That's the most important thing, to make that clear for everyone. Treating obesity, we're talking about people who are obese and overweight, which brings consequences that can be life-threatening, right? Of course. Not to mention a heart attack, not to mention respiratory failure, diabetes, or hypertension, of course. Sleep apnea, and in men, decreased sexual potency.
Erectile dysfunction?
Yes, erectile function and the consequences this has for marriage, family, and relationships. People who only want to lose weight for aesthetic reasons can obviously get injections. With this, they will stop eating, they will lose fat, they will also lose muscle, and they will also feel... How do you say it when a person feels dizzy?
Yes.
They will feel listless, weak, they may experience vomiting, they may experience diarrhea. I'll tell you more. I don't know if I can share personal experiences.
Of course, yes.
But I had a patient, this was in Sweden obviously, who came to the emergency room because she got these types of drugs illegally, right? In a country that isn't Sweden. And she injected a high dose. She came in 2 days later completely dehydrated with some really significant electrolyte changes. Her potassium was extremely high, her sodium was extremely high. She had severe hypoglycemia due to intoxication. And obviously we had to admit her to intensive care. Well, people who work in intensive care know how hard it is to correct all those things, how many days it takes.
How many days in the hospital? No, there's no antidote for these? No. You can't. There's nothing known that can clear the GLP-1 when a very high dose has been administered.
I can't give you an antidote for GLP-1. I took a high dose, I give you an antidote and we fix it. That doesn't exist. No. So, going back to your question, if you need to lose 3 or 4 kilos for cosmetic reasons, this is not the way.
No, this isn't hyaluronic acid or botulinum toxin. It's a powerful treatment.
It's not recommended. And honestly, I don't know if there's a way, a magic formula to lose 3 or 4 kilos in a week. Of course, unless I don't know you know more about it, yes?
No, look, what is clear is that these drugs help, even if that's your goal, but they come with other risks that are very important, right? So, people are going to keep misusing it. Now we'll talk about off-label uses, right? But first, let's talk about approved uses. That is, the regulatory agencies tell us, okay, here are some drugs that have been approved by the European Regulatory Agency or the FDA in the United States. All right. Now, you can't use it for everything. You can use it in these cases. What are those cases?
What is recommended in Europe nowadays is patients with a body mass index greater than 30. We can also discuss what a body mass index over 30 means, especially for those unfamiliar with it. Or patients with a body mass index greater than 27 but who have some type of comorbidities. What would the comorbidities be? Diabetes, hypertension. That the body measurements are out of balance, right? Of course. So only then can we start to think that yes, we accept this patient in order to...
You are a candidate, you meet the criteria for these medications. Exactly. Okay, however, that would be the official guidance. I also have my own controversy and debate because the marker that determines if a patient is suitable or not is still the body mass index, which we know is quite limited. There are patients who might have a BMI of 28 who would be excluded, but they have a very poor body composition, right? They have the typical sarcopenic obesity, a lot of fat, very little muscle. Or there are patients who, well, according to this criterion, there are many bodybuilders, for example, who have a BMI of 32 or 33 or even higher, who wouldn't be candidates for GLP-1 because they don't have fat, it's all muscle. So, in the end, BMI is very limited here, and I understand that it's the easiest way to set more or less clear eligibility criteria, right? Many people who could benefit from the medication are excluded due to the criteria. I'm curious what you think about that.
No, I think exactly like you. Now, that's why it's very important to emphasize to the people who are listening as well that this has to be a medication. That you can't buy it by yourself and you can't inject it by yourself. It should be administered by a professional who knows what they're doing. We're talking about professionals who know how to handle these medications, right? Of course. If we have a patient, like you mentioned, a bodybuilder with a body mass index of 31, but the body measurements are very, very, very healthy, right? Very well. That patient shouldn't be receiving GLP-1, of course. Now you could have a patient with a body mass index of 26.9, I mean below 27, but their body measurements are completely abnormal with a lot of fat. Yes.
A lot of visceral fat, right?
Exactly, very high. That patient should receive the treatment.
Okay, that's where off-label uses would come in, right? Off-label, outside the approved indication.
Exactly. But even if they're on label, even if they're within the indications are always just recommendations. And doctors, this is what a professor of mine told me when I was working as an anesthesiologist with Kaplinsky. We doctors have the obligation to either go off-label or stay on label.
With judgment?
With judgment. I use my own judgment. If I have a patient with a body mass index over 31 and they meet the label criteria, but I see that they're a bodybuilder, obviously my judgment tells me not to treat that person. That's just how it is. But those are the indications. Body mass index over 30 or over 27 with comorbidities. Those are very general indications, right?
Of course, the risks come when that professional judgment doesn't exist. That is, when someone on their own, at their own risk, starts using these drugs, and there are many ways to do that. Now let's talk about online stores, online peptide sales. It's crazy. I've been looking into this topic to prepare for this episode. With just 2 clicks, you can buy unapproved drugs. We'll discuss retatrutide in the United States soon, and YouTubers are already making videos about it. But how is that possible? Yes, we'll discuss that, right? It's really crazy. This isn't regulated or at least penalized, right? You also work with websites. You work in emergency services with the company Yafen, right? Which in the end is dedicated to prescribing GLP-1, but not just that. I want us to go deeper now into what you think is the main mistake that happens in most systems for prescribing GLP-1 medications. We've discussed this off camera and agree support is lacking elsewhere since a patient with obesity can't be treated with just medication. There have to be other elements that go along with it. What are those elements?
Well, I think Dr. Borja Bandera, to answer your question, because I work with Yasen, Yaken is a company that combines not only pharmacological treatment, which actually, and this is important, pharmacological treatment is an important part. But that's not all, as you say. And that's very important to understand. Yasen combines pharmacological treatment, dietary or nutritional treatment, and psychological treatment.
Okay.
And coaching. Because coaching is also very important, right? We'll talk about that, because understanding how obesity works is what's important. And I remember that 10 years ago, talking about being obese. So, an obese person was someone who was sedentary, who didn't have willpower, someone considered, as we say in Argentina, I don't know how you say it, lazy.
Yes, it's the same, a stigma that still exists here in Europe too.
But it's incredible, isn't it? When you start to understand how the brain of an obese person works, how their body works, you understand that an obese person is not lazy or sluggish or sedentary, but that many of them really try to lose weight. They do everything they can without success.
Of course.
So, Yasim combines everything an obese person needs to be able to reach their goal of losing weight, maintaining their weight, and keeping it off for their whole life. Because what they really need is to change their lifestyle.
You mentioned nutritionists, psychology, and coaching.
And coaching, yes. And doctors.
Right, and doctors, obviously.
And doctors who know how to treat these patients. Because Yassem even has his own training for doctors. It's not that you're a doctor, you have your license, or even that you're an endocrinologist, because endocrinologists know much more about this, right? You have your license, we accept you at Yassem, and you start prescribing these drugs. No, Yassem trains its doctors before allowing them to prescribe.
We need to provide training in obesity because even among endocrinologists, there are still big knowledge gaps about obesity. Obesity is extremely complex. I would say that in my specialty, it's the most complex disease that exists. If you really want to understand the pathophysiology, how the brain of an obese person works, you have to learn about behavior. You have to learn a lot about coaching, about behavior. You have to learn a lot about nutrition, a lot about exercise. You have to learn about lifestyle. That's not covered. Medical school and even endocrinology residency don't teach us that.
So even now they're talking. My boss was at an obesity conference, and there's talk of a specialty dedicated to obesity.
To obesity. To obesity, yes, a subspecialty. A subspecialty. That would be great, and it's a necessity. Just one question, the physical exercise part, who covers that at YACE? The coaches cover it. The coaches? Okay, got it.
Generally, many of them are trainers.
They have training in physical exercise. In physical exercise, yes, great, perfect. Okay.
And well, but then, sorry, Borja, going back to the question of whether it's just a medication or not. What I always say is, it's not just a pharmacological treatment. And I usually tell this to my patients, right? Especially to those who are just starting, because it's important for them to understand that. We're going to put you on these medications and you're going to feel less hungry. Therefore, you're going to eat. The portions you eat will be smaller, much smaller. Now you can eat a small portion of chicken or you can eat a small portion of cake. Chicken and cake have very different calories. You'll eat less today. Instead of over 10 portions of cake, you'll have this.
Cake is tarta in Spanish, just so people know. That's where we also get confused. But yes.
Good thing you know about Argentina.
Yes.
All right, chocolate. So now, do you want to lose weight? It's very important that you maintain a calorie deficit, right?
Right, of course.
And you achieve a calorie deficit by learning how to eat. And that's why it's important to have nutritionists who help you understand that, right?
Yes, Christian, I saw this problem daily in my practice. I mean, I had the feeling that for the first time we have very powerful and effective tools for obesity, but I can't just give the patient semaglutide and forget about them. Because that patient is going to fail or become dependent on the medication to lose weight, so they won't develop the necessary habits. So I couldn't leave the consultation without explaining that it wasn't just about eating less, but that they had to change what they ate. That they absolutely had to do strength training to avoid losing muscle. That made me feel powerless. I'm talking about my years in the hospital, right? The fact is that these are systems that aren't well structured, not well designed to provide for or cover the needs of obese patients, which always require a multidisciplinary treatment. I mean, it's not optional, it's always multidisciplinary. If we only focus on the endocrine aspect, if we only focus on medication, then failure is guaranteed. Those who already have some good habits and somehow manage to develop others on their own won't fail, but most will fail because, as you said, there has to be the nutrition part, the training part, and the psychology part, which is crucial.
Let's discuss the psychology aspect, for example. I have many patients who have extremely high stress and everything that comes with cortisol and so on, which is another topic, right? They don't sleep, they don't rest, they have psychological problem, psychiatric problem, psychological issues, depression, right? And they think that just taking these medications and not addressing the psychological problem is going to bring results. And for example, lack of sleep totally affects our bodies, right? Therefore, the need to have psychologists also working with these kinds of people is very important.
Yes, without a doubt. Let's talk about the benefits. That is, what kind of weight loss or fat loss can we see in these patients? So, what do the studies tell us about what we can achieve? I have some figures here, right? You see this in your daily practice, so I want your real clinical experience, not just clinical trial data, but what you observe in your day-to-day work.
Well, we have goals every time we see our patients, right? There is a general set of goals, but there are also individual goals for our patients. We try to assess each patient individually. A 75-year-old patient who has been obese all their life is not the same as a 25-year-old patient who has only recently become obese. Exactly. So, what we can expect from a 25-year-old patient is not the same as from a 70-year-old patient. You mentioned some studies. I was reading some studies. Many of them, unfortunately, are not, as we say, adjusted for confounders. I don't know if, yes.
To the confounding factors.
Exactly. That kind of somewhat limits their validity, right? Putting a 75-year-old patient together with a 25-year-old and examining them both at the same time is something that shouldn't happen. Instead, you should adjust for confounding factors. Now, what we do see is a pretty drastic reduction in weight at 3 months in most patients.
By 3 months, there should already be
at least more than 5% weight loss if they do exactly as we tell them. That's also a factor that plays a big role. Unfortunately, Borja, culture plays a major role. It's not the same response we're getting from patients who have a higher academic level, who have a higher economic level, as from patients who have a lower academic level, an economic level.
That's what I was saying. I don't think the economic level compares to Spain's, right?
Unfortunately, no. Unfortunately, but you can really notice the difference between the Swedish patient and the Spanish patient. I work with Swedes and Spaniards, and the differences between Swedish and Spanish patients are clear. The Swedish patient has the possibility to adapt their diet. They have the possibility to adjust the medication because we change the dosage of the medication, depending on the response to the doses, right? And the Swedish patient doesn't have a problem adjusting their dosage to high doses, for example. Unlike the Spanish patient who must adapt due to costly medication, unfortunately, of course. But I would say that we have a very high rate of patients who lose at least 5% of their weight in the first 3 months. Then the challenges start, which is another matter. I don't know if it's called challenges, but that's when we get into the treatment itself, right?
Uh-huh. Okay. Well, actually, if we look at the clinical trials, the numbers are even higher, right? I have here, for example, the famous Step 1 semaglutide trial, which talked about 15% already at 68 weeks, so in the long term.
We're talking about the long term, yes. What these studies also show, that's why I'm telling you, I'm talking about a 5% loss in the first 3 months, and at 68 weeks, 15% yes. That in reality, we're talking in this case about semaglutide. Then we have, if you allow me, the redefined one, for example, which is the Sormant one, which is tirzepatide, it already brings it up to 20.9%. Yes, that's what happens at 72 weeks, which is the famous Monjaro, as we call it.
So people have a comparative context. Normally, with diet alone, a very successful weight loss could be 5 to 10%, and very few people achieve that. And with bariatric surgery, the most aggressive treatment we have for obesity, you can see 25 to 30% weight loss, okay? Which, if everything goes well, the new treatments are already getting close to those numbers. For example, retatrutide, right? It had an average weight loss of 28 or 29%, if I remember correctly. So, these are drugs that are becoming similar to bariatric surgery in terms of weight loss. This has never been seen before with any medication, right? That it could be as effective as surgery.
And I was talking with a friend of mine who's a surgeon, and he told me, these are going to put us out of work because these medicines are going to replace bariatric surgery in the future, right? Or at least...
Of course, and for me it could do that. For me that's success as well, because obviously the side effect profile and complexity of bariatric surgery, even if it's done by the best surgeon in the world, is much higher than just taking a molecule, which in addition has been approved, right? So, cutting the intestine is never going to be the same as taking a molecule. For me, it's a success for medicine, but obviously we'll have to change our mindset a bit, right? Maybe in 20 years. Years from now, let's say, people will say, these crazy people who cured obesity by cutting the intestine, right? How could they do that? Yes.
Yeah, and this, yes. Honestly, I think we're heading toward a change. These types of drugs are bringing an incredible change for the future. Not just bariatric surgery, which personally I think is going to disappear.
Would you say they're going to disappear?
I think they'll disappear unless some can't take these medications, in which case we'll keep doing bariatric surgery. But, or at least that's my hope. My hope is that they disappear. Of course, because I think bariatric surgery, I even had patients who regained a lot of weight after bariatric surgery and you can't do it again. No. And with bariatric surgery, many of those patients are operated on and then left aside without treating everything else, right? You have to keep eating with a caloric deficit, you have to keep taking your vitamins, you have to keep working out, you have to think about your calories. Just because you had bariatric surgery doesn't mean you'll keep losing weight forever. We had many patients who gained weight again, they had their bariatric surgery, paid for it out of their own pockets, and then they come to us for this kind of treatment. And another thing, the bariatric surgery has already been done. We can't undo it. It's already done. With these medications, if something happens, you just stop taking them and things correct themselves, right? Exactly. So it's reversible, unlike surgery.
If we do a gastric sleeve, it's done. If we do a Roux knee bypass, it's done. It's not reversible. It's not reversible. That's another point in favor of the medications.
Yes.
And Christian, now we've talked about fat loss. We've already said that they have very powerful effects, but those aren't the only benefits of GLP-1. Let's talk about extra adipose benefits, right? In what other ways can GLP-1 help us? Because they protect the heart, they protect the kidneys. In what other ways do they help patients? You see them, people say they've lost fat, but what else do your patients mention?
Well, cardiovascular protection, hypertension, for example. In my experience, I see a lot of patients, and actually this is something we give to our patients when they start. If our patient comes in and shows us that they're taking 2 or 3 pills for blood pressure, for their hypertension, we already raise a warning flag where we say, well, your blood pressure could drop, and it could drop a lot, so we need you to monitor your blood pressure continuously. And really, many of them stop taking their pills, or instead of taking 3 pills, they start taking just 1, because their blood pressure drops a lot, which affects the protective effect on the heart muscle, right? On the heart, of course. And also, these types of analogs directly protect the heart. I mean, not only do they tackle hypertension, but they also protect the muscle.
Because receptors, we haven't mentioned this, but GLP-1 receptors exist in all organs. Exactly. In the heart and in the blood vessels as well.
Exactly. In the endothelium, right? Speaking of blood vessels, the renal protection that this can provide, better glomerular filtration in the kidney. Protection against what are kidney inflammations, but also kidney failure. So it's not just treating hypertension, it protects your kidney much better, right? Of course. And then I made a note of sleep apnea.
It's very important.
Super important. Imagine, and I always say this and I tell people, imagine having a wife or a husband. I usually pick on men more sometimes, right? Well, no.
But we don't deserve it.
We don't deserve it. But having a husband who is, do you call it snoring at night?
Snoring, yes.
Who is snoring all night, right?
No, that's unbearable. That's insufferable.
But it's incredible, isn't it? But imagine if your husband loses weight, if he has less, if that lung can expand in a better way. That the airways aren't tight, that there isn't any pressure against your airway, but that they can really have their elasticity, so that air can enter better, so that the face can move more freely, right? And that sleep apnea disappears, so that the patient can and that sleep apnea affects quality of life because people sleep less, of course, because they have sleep apnea, or they sleep worse, as we say. The quality of sleep is much worse.
At the same time, we remove another cardiovascular risk factor.
Another cardiovascular risk factor. So people lose weight, sleep better, breathe better at night, snore less, the wife sleeps better, the family is happier.
Everyone is happy.
And speaking of marital matters, right, which is very serious to me. I had patients, male patients who were 60, 65, 60, 70 years old, who resumed sexual activity, regained their sexual potency.
That's gratifying, isn't it?
Incredibly gratifying. Their testosterone, because we measure testosterone in our patients, their testosterone increases and increases without medical intervention. It's not that we give them extra testosterone.
Of course, no, there's secondary central hypogonadism caused by obesity, which is well documented and it resolves. It's a functional hypogonadism that resolves.
Exactly. So having that function, that sexual potency, having it return to the body, that the person can produce, that they can really have marital relations again. This is very gratifying. Exactly.
Obviously, joints as well, osteoarthritis, arthrosis and joint pain improve a lot, right? In fact, there's also a study there that I don't remember, which measures exactly this. And then there are other things that are more emerging, more novel, maybe more anecdotal, but they're starting to form a body of evidence, and that's something I'm very interested in, the issue of cravings. Exactly. The issue of tobacco, alcohol, other drugs, addictions, it's about addictions.
You took the words right out of my mouth.
What's going on there? What's going on there?
What we see is, I've even had patients who tell me, Doctor, I don't know why. And many Spaniards say, Doctor, I don't know why, but I'm drinking less alcohol. I even had a patient who told me, I think I'm going on vacation, and I would like to stop the treatment when I go on vacation because I want to drink alcohol. My answer is no, please don't stop, just stop drinking alcohol. You don't need alcohol on vacation, right? But yes, much less alcohol consumption, precisely because of what we talked about regarding the brainstem. The brainstem, right? In the brain, since the dopaminergic system is affected, there's much less cigarette consumption, they smoke less. But even these anti-craving effects, if we take them further, there are people who become less compulsive, right? They buy less, spend less money, and they actually avoid those compulsions they used to have, right? Of course.
A strong point is you'll spend money on medication but save on clothes or other things.
We use that as an argument. We use it as an argument for many people because obviously medications are expensive, and it's a shame that they continue to be so expensive that they're not subsidized. We can discuss that later, Dr. Borja Bandera, if you want, but it was unscripted. How many fewer hospitalizations will we have if people lose weight? If we have fewer obese people, we'll have fewer hospitalizations. Yes, we'll have less need for intensive care. We'll have less need for expensive treatments for inflammatory diseases. Rheumatologists will have fewer patients. But nevertheless, we keep paying for and subsidizing all those treatments and not these drugs that are going to prevent the need for all those treatments, right? Of course. The drugs are expensive. And what I meant by that is that many times we can't treat our patients optimally precisely because their financial situation doesn't allow it.
Yes, without a doubt. It's a huge barrier to entry.
But then, when they want to stop, when they say, well, no, unfortunately, I can't pay for more treatments, we try to explain to them, well, but there are many things where you could save. You could save on your diet, try to eat as healthy as possible, and make it as cheap as possible. But in the long run, you'll benefit. You'll take less medication, and you'll be hospitalized less often.
Surely, on balance, there is definitely an economic benefit in the long run because, like you said, in the end, you will prevent complications, improve your quality of life, you'll be more productive, and you'll enjoy life more. Surely, if you look at it, maybe not in a year's time, but in 10 or 15 years, surely everyone will save, or almost everyone.
What are we doing today? That person often can't afford to buy it.
They don't have it, or they don't see it, or they just don't see it. Of course not.
Yes, it's difficult. A challenge we face today.
Well, it's crazy that a molecule produced in the intestine can generate all those effects, right? Behavioral effects and changes in behavior. Let's get into the more, let's say, negative part, the side effects. Because in the end, it's a drug. Every drug has side effects. None are exempt. So let's explain all of them, from the most well-known ones, which are the digestive ones, to others that might be less known. I'm especially interested in the muscle issue, okay? First explain the digestive ones to us, then we'll cover the others.
I like that you said every drug has side effects. We had a discussion with a colleague quite some time ago who told me about acetaminophen, a drug that's widely used everywhere. Yes. If it were invented today, I don't know if we would authorize it. We know so much about acetaminophen intoxication, and it's sold everywhere. I mean, anyone can go and buy acetaminophen and poison themselves.
And the dose doesn't take a very high dose to poison yourself. People don't know that. No.
People don't know that. Well, no, yes, but yes. See. And these drugs, let's start with the most common side effects. All gastrointestinal issues, diarrhea, vomiting, constipation. Now you have to understand that diarrhea, vomiting, and constipation are directly related to the effect these medications have. Of course, intestinal motility is much slower. Some people talk about what is called acidity, right? Yes, dyspepsia as we call it. Doctor, ever since I started these medications, I've had constant heartburn. You see, and I feel awful, and I have terrible nausea. It's closely related to the dosage and to the patient's diet, because many people take these drugs and keep eating like they did before taking the medication, without understanding that their intestinal motility is much slower, of course. And that's where we get to what you're saying, right? That we have to treat our patients as a whole, teach them how to eat as well. And the truth is that these issues are solved by adjusting the dosage.
Or by properly titrating them, meaning gradually increasing the dose.
Titrating them properly, knowing when to increase, how to increase.
Or reducing when it's necessary to reduce.
A clear example is the current recommendation, depending on the drug, to double the dose after 2 weeks. But what we say is no. After 4 weeks, you evaluate if your patient needs a higher dose or not. How is their hunger after 4 weeks? How is their satiety? How are their cravings? If the patient says, no, I'm not hungry, I eat in a caloric deficit, and I'm not hungry, I don't have cravings, and I feel full very quickly, we don't need to change the dose. Now, if my patient comes to me after 2 weeks and says, I have a lot of diarrhea, I lower the dose, of course, and the diarrhea problem is solved. I mean, generally, those side effects are very well controlled.
Some more serious ones also affect the digestive system, but they're less common, like pancreatitis or paralytic ileus, digestive obstructions, or, well, mainly those two.
And the ileus is very closely related to dose. Why? Because it's an ileus, much more of a mechanical ileus, often due to obstruction, like when they have fecalomas, right? As for paralytic ileus, honestly, I've never seen it myself. I've treated many of these patients and haven't seen ileus. And pancreatitis, but extremely few cases.
Very few, right?
No, yes. I think we have to be very careful and say these drugs can cause pancreatitis, because yes, they can cause it. But how many patients? I mean, yes.
It's very, very rare.
There are very few patients.
Likewise, if there is a history of pancreatitis, then yes, it is contraindicated.
That's a different thing, right? Like thyroid issues, thyroid cancer, for example, right? Yes. Also, right? We need to know about medullary.
Right.
Exactly. Medullary breast cancer can have
Yes, although it's more a matter of caution than anything else, because really, I mean, the studies that talked about that caution were mostly preclinical and so on, I mean, in mice. But well, yes, in the end, you also have to screen for that. What worries me even more than all of that, more than everything you've said so far, is the issue of muscle. For me, the big weak point of these drugs, if not used properly, is the muscle. Because muscle is equal to metabolism, longevity, quality of life, dependence, or functional independence. So, there are some facts that really alarm me, and for example, with semaglutide, we have data showing that when there is no strength training, up to more than a third, between 30 and 40% of the weight lost, is lean mass. In other words, out of every 3 kilos, 1 or more is muscle if we don't do strength training. If we do, it's minimized. The loss is almost eliminated. So tell us, do you see patients who unfortunately don't exercise and lose muscle? So tell us.
Yes. Muscle loss is a reality. I mean, if it's done in an uncontrolled way, the patient is going to lose a lot of muscle. That's a big problem, isn't it? What do? If we see patients losing muscle, that's when we start dietary treatment. Protein intake is vital for these patients. Understand that at least 1.5 grams per kilo daily. What kind of protein should they consume? Yes, at a minimum.
Yes.
Please, more than 2 at least.
These patients have a large caloric deficit. The greater the deficit, the more important protein is, which the audience may not realize. In this case, these are patients who are in a large caloric deficit, sometimes more than 1,000 calories, right? Because in the end, patients with obesity came from a significant caloric surplus, and it gets reduced a lot. But that's the nutrition part, the part about mechanical tension and physical exercise. I mean, I think that's indisputable. It can't be replaced, no.
Well, exactly because of that. First comes nutrition, but what's really important is physical training. And lifting weights, stimulating your muscles, right? Because there are people who think, I'm training every day. I've had patients say, I train 5 times a week. Well, but what do you train? No, I run or walk. Of course. And well, but are we stimulating our muscle growth? No. So it's really important for people to train. Understanding how to train, lifting weights, stimulating your muscles is important.
Yes, anything is better than nothing. But unfortunately, even if you go swimming or do cycling or go running, in Switzerland and Sweden, there's a big passion for endurance sports, right? But it's not enough in this case. I mean, it's really part of the treatment. It has to go hand in hand. Do you know what happens when people lose muscle using these drugs? They guarantee the rebound effect. In other words, they guarantee that once they lower the dose or stop the drug, they've lost muscle, metabolism, basal metabolism, and calorie expenditure. They're in a much worse starting position than before because they gain weight faster than they did before since they have less muscle. So they use the drug again and lose even more muscle. And they start going through very dangerous cycles because after a few years it causes sarcopenia in a patient who might already be somewhat frail. So for me, this is no joke. I mean, these drugs are excellent. Only if they're accompanied by all of this.
Yes, and I think there's a myth, a stigma that by running and doing aerobic activities, especially extreme ones like enduro, like you told me, that's the best way to lose muscle. To lose weight.
No, of course.
But actually, these patients need to do weight training.
Yes, without a doubt.
And that's what's going to help them lose weight in a...
And for me, that's the big challenge because it's really hard for them. Keep in mind that these are patients with obesity who have been obese for decades, who have never set foot in a gym because of the stigma of obesity, of course. They're embarrassed to exercise around others. That's the challenge. And here, there needs to be someone with professional training in physical exercise who takes these patients and tells them, come on, if you're embarrassed to go to a gym, let's do it at your home. If you're embarrassed at home, let's do it here. Give them options and alternatives to stimulate the muscle. Because it's really simple actually, with 20 to 25 minutes of properly done strength training, which can be with your own body weight, with resistance bands, there are 1,000 ways. Very simple. But make sure to guarantee that minimum effective dose of that medicine, which is physical exercise. I think that's absolutely essential and undeniable. And with my patients, it's also very hard for us. I mean, it's really tough for us.
Yes, this is something cultural and it's the same in every country, everywhere, right? Understanding that in many places, in many gyms, the people who go are the ones who are already in the best shape, of course. They have the kind of physique that's culturally idealized, right? They're the attractive ones, as we would say.
And that turns people away.
And that turns people away when the people who need to go to the gym the most are not exactly those people, but rather the ones who really need it. People with obesity, people who are overweight.
Exactly, yes.
And how, well, now we're talking about something that goes beyond what's ideal, but it would be great if, as a society, we understood that it would be really good to have these kinds of people in our gyms as well.
Right? No doubt.
And help them. I mean, like, okay, you're obese, come with us, let's go, let's work out. I mean, help them, because unfortunately the stigma they face is really high, right? Many of them have depression, precisely because of how their bodies have looked their whole lives, unfortunately, of course.
You were just talking about depression. There's a very controversial topic that has come and gone several times in the history of GLP-1 drugs, which is the following. Do these drugs take away your will to live? I mean, is there a higher risk of suicide? Is there a higher risk of taking your own life? Because there were several warnings that were published. Where does this stand now? Or, I'm almost more interested than the regulatory side. What's your experience with patients? Yes.
Well, the warnings were there before. The FDA removed them. So they no longer have a warning about this. There's no longer a suicide risk with these drugs. Experience, that's what's important. My patients are much happier. Imagine I had several patients and I can share many experiences. I can show them, they want to share their stories, but that's how it is. The patients lose weight, they have much more energy. Just by losing weight. That makes them much more productive because they have more energy. Being more productive helps them sleep better. And what that does to the body feels happier, right? Of course. Or what it gave us, we were talking about men, much more potency, much more satisfaction, and women, much more satisfaction. So, no, on the contrary, I think my patients are much happier because they've lost weight.
Yes, I also think that for the patient for whom it works and the treatment is effective, in general their mood improves a lot.
And no, I didn't have any I didn't have any patients who had an increase in suicidal thoughts or whose psychiatric treatment got worse. Honestly, I didn't have that. So no, I can't say that that's true. And the warning, thank God, was also removed.
It was removed, yes. And Christian, there's a very important topic, which is a question that many patients have. Many patients say to us, well, doctor, okay, I'm going to start a treatment, but is this treatment for life? Will I have to take it forever? Will I be able to stop? How is this going to work? That causes a lot of anxiety, doesn't it? So what would you say to these patients? Do you think that's a good question? Do you think obesity, first, we should start there. Do you think obesity is a curable health problem? Can it be cured or not?
Well, we talked about the personal side, so let's talk about what the scientific evidence says. The scientific evidence is still a bit inconclusive. Personally and unfortunately, I don't think so. A person with obesity will always have a slightly more extreme brain activation when it comes to food, right? I mean, an obese person, even if they have a thin body, will still be obese in their brain, unfortunately, because of all the changes their brain went through before, right? Hypothetically speaking. Therefore, and I don't like it, but there is a relationship between alcoholism, for example, or smoking and obesity, right? Especially alcoholism, because the alcoholic is an alcoholic for life, even if he's sober for 10, 15, 20 years, right? He will always be an alcoholic, unfortunately. Therefore, I try to explain to my patients that the thought shouldn't be, when can I stop the medication? But rather my thought should be, how many years can I? Can I stay on a small dose? One that suppresses my hunger and helps me keep my ideal weight. Yes, and I compare it to diabetics or people with high blood pressure. I mean, someone with high blood pressure often has to take pills for their whole life, right? A diabetic often has to follow their treatment, even if it's just dietary, for their whole life. Of course.
Yes, it's true that it's a useful analogy because people don't question. For example, someone who takes enalapril doesn't ask, doctor, but when I stop taking enalapril, will my blood pressure go up? Well, probably yes, if you haven't done other things, right? It's the same with obesity. Doctor, if I stop the medication, will I gain weight? Well, statistics tell us that most likely yes, unless you've made a really, really drastic lifestyle change. Exactly. So, right? So,
my answer is I don't know, but my goal is that your first thought isn't to stop the medication, but that your first thought, as you say, is to create a lifestyle that after a few years, after a few months, allows us to start trying. Let's try reducing the medication and wait 2 or 3 weeks. How's your hunger? Yes. Can you control your calorie deficit? Or not a calorie deficit, but can you control your hunger? Or did you start eating? No. Well, I started eating? No. Let's start the medication and wait a few months, of course. The same with Anapril, the example is very clear. I mean, let's stop the Anapril because your blood pressure is very low, but what happens in 6 months? Do you understand? What happened to your blood vessels? Of course.
So, the answer is, in some cases you can stop it and it works, in others it doesn't, in others you have to keep a low dose, right? For example, I find the whole question of dosing interesting. Now, there's another trend in the United States, there's always a new trend in the United States about microdosing to maintain the weight loss. So, using very low doses to maintain the weight loss, right? And never stopping it. What do you think about this, about a low maintenance dose?
What do I think? Personally, I'm very much in favor of that. Well, I think it would be very beneficial for this type of patient. I mean, if you have an obese person who lost a lot of weight and manages to maintain a very good lifestyle, personally, I don't see any issue beyond the economic aspect, Of course, if they can afford it, if they can pay for it, we keep a small dose so you don't go back to the life you had before, right? Of course, we changed your life. Your life is different. So if we can keep you on a small dose, a microdose as you call it, I mean, it's something we do at the SEM. We try to find a dose, the lowest possible dose, that keeps your hunger under control. That helps you keep your ideal weight, right? Helping patients maintain with microdoses. And obviously, in very few cases, and unfortunately I have to say it, Borja, in all the years I worked with the SEM, there were very few cases where we were successful in withdrawing the medication.
Completely.
I mean, we discharged the patient, we cured them, as it used to be said. The truth is, there are very few cases like that. But I don't want to say it in a negative way because I think that's also a myth among people nowadays. Seeing it like, no, I'm going to be dependent on the medication, so I won't take it. They view it as very negative, but it should actually be seen as positive. Today, there is a medication that can help you change your life, to extend your life by several years. I mean, we're talking about adding years to your life, of course, and to have a quality of life that, because of your obesity, you don't have right now. So, why think of it as something negative? Why not consider staying on this medication for life but completely changing your lifestyle?
I mean, yes, I advocate for that, for not immediately going to that thought of having to be on medication for my whole life, right? I think there's a fear there of, I'm going to become dependent on this. No, you won't become dependent, and later we'll assess whether it can be reduced or stopped. But at the beginning, well, let's start getting better, right?
Exactly. And I think if we manage to change your lifestyle, let's try it. And if you manage to stop taking the medication, perfect. We've made it.
What about, well, the concept of non-responders, right? Are there really people who don't get any effect from this medication? And if so, what's behind that? What kind of profile do they have? Why? Is it because their physiology is different? Is it because they don't take it properly? Or is it because they have other serious problems and compensate for it? Or because they drink alcohol? I've also seen some cases, right, where they compensate with other liquid calories. What's behind these non-responders?
You can read this everywhere, right? But the responders, the non-responders we usually work with are people who, first of all, have been obese their whole lives. They had a lot of problems with obesity and severe obesity. I mean, we're talking about a body mass index of 38 or 40. Very serious, right? And it's not just their system, their body, but also their mind as well. The psychiatric and psychological aspects of people are disturbed, right? It's much harder for them because you can stimulate the GLP-1 pathway, but the psychology of people also comes into play. They are the people who have more difficulty responding to these drugs, the non-responders.
Obesity is probably much more serious.
Obesity is much more serious. We always try to inform them that we're going to start with a low dose, but that they should be prepared to increase their dose, right, in a short period of time. So those are the patients that we really see as having a problem with response. And those who have diseases like other types of
Other comorbidities.
serious ones, right? For example, when they have very advanced diabetes and they need many doses of other medications to control their diabetes. For example, uncontrolled high blood pressure that requires several medications to control it. Or those who have already had heart attacks, or who have kidney failure, their bodies are already damaged. In those cases, we do need higher doses, right? For those who are non-responders. Very few actually end up not having a response. They just don't respond. But there are very few. And some have these mutations that just won't respond anyway, but we're really talking about very few patients. I had a patient who didn't have any response, of course. And she wasn't that obese. We even reached such high doses that she didn't respond, and we had to discontinue the treatment.
And there's another topic I've mentioned to you before that I think definitely needs to be brought up now that we're finishing, but I think we need to open it up, and that's the issue of online peptide stores, right? I think this can't have been around for long, at least I've only seen it recently, but like I was telling you, doing a bit of research for the episode, I thought, how does this work? That I can buy, GLP-1, even retatrutide, which isn't approved in Europe. I don't know. I see here a patient. I'm not going to mention them because, no.
No, let's not even mention her.
So people don't go looking for it, but you could buy retatrutide with cagrilintide, which is something that's still completely under investigation. It's being invented. It hasn't even been approved yet, but with just 2 or 3 clicks, they'll deliver it to your house. So under what regulatory framework, how is this allowed? I mean, what I don't understand is how to approve a drug. It's years and years, sometimes decades of phase 1, 2, 3, 4 clinical trials, of approvals by the FDA, by the EMS. And now there are people here selling this, I don't even know where it comes from, in unregulated online stores, and they can't take them down. I mean, how does this even work?
Well, I think legally they always find ways, right? But there are 2 things. First, the illegal part is that we don't know what kind of drugs they are. Since they're unregulated, we can't confirm if they're the original drugs.
Right, or if it's something else.
Or if it's something else. And if they're the original drugs, what kind of manufacturing process is behind them? I mean, is it produced in a reliable, regulated way? Or is it made in an unregulated setting, so you don't know how well the molecule was produced? Molecula. With all the harm that a poorly produced molecule could cause to the body, right?
For example, autoimmunity, giving a molecule your body doesn't recognize can trigger autoimmune reactions, which have already been reported with these peptides, of course. Even diabetes, which in the end is induced by these drugs through autoimmune phenomena. Yes.
But the toxicity it could cause to the kidneys, to the liver, well. And the second thing is this, the lack of supervision by a professional who knows how to treat these patients. Because, for example, you could buy it, or if someone buys this on the black market, as we call it in Argentina. But what professional will guide you through the treatment? Would you know how to use it?
No, nobody.
And if you take the drug and end up in intensive care because of intoxication, because of acute dehydration that caused severe kidney failure, then the danger is very great.
And they're being used widely. That's right, they're being used widely. It really surprises me. And every day people ask me, what about this BPC for my tendon since I have an injury? I say, look, I've done a simple literature search and there isn't a single study in humans. There are 3 studies in rats, but not a single study in humans. So what can I tell you? No, don't use that, don't take that.
So I think what's important for people to understand is, don't visit those websites. Don't take anything without a doctor who knows, without professionals who can guide you. And it's important to say this. Don't take anything unless a professional tells you to. Because many times you think, I'm overweight, I'm going to take GLP-1, but maybe you don't qualify. Right. Maybe you don't need it. I mean, it's incredible that these websites exist. But the black market is always there. Yes.
But the fact that there aren't any legal tools to stop that seems really absurd to me, right? But well, that's the reality.
Well, and most of them go through countries that are more legally lax too, right? Of course. So it's like drugs, right? Drug addiction, drugs are sold everywhere, unfortunately, right? Yes, that's true. And yes, it's very difficult to regulate it. I think teaching the population about this it's about educating.
Education is what it comes down to. That's all that's left.
That's all we doctors have left.
And Christian, for every patient or person who recognizes they have an obesity problem and hasn't been able to successfully deal with it until now, tell us a little about how Yakin, the company you work for, can help them. I mean, what should they do and how can it help them?
Well, the easiest thing is, please check out yaxen.com. We go to yaxen.com and there are a lot of things. We even have free tools for people who can't afford the membership. There are free tools. No, you don't need to be a member to get benefits from the company. But the first thing is, when you arrive at yaxen.com, we do an evaluation of the person. We see if the person really needs our treatment, we offer them the treatment, which is not only pharmacological. Again, but we offer a tool, a set of tools to tackle obesity, which is, well, physical training, dietary, psychological, coaching, and a daily journal so you can access your doctor every day for treatment.
You can contact the doctor daily.
You can contact the doctor daily. We have a response. We guarantee a 24-hour response. That's great. So, if the patient took their medication today and something happened, we will respond within 24 hours. Personally, if you want me as your doctor, I try to, if there is something that is very, very urgent, I call my patient directly. Yes, because yes.
It's something very personal, right? Very close.
And always, what I really liked a lot about Yaxen as a company is that the real goal isn't to make money, but to truly help the patients, right? Clearly, for us, even as a private company, it's about helping the patient, right?
So, accompanying them on this journey, for me, the word accompany in obesity is key because I go back to the same point. Patients feel so alone. When they go to the doctor, they're prescribed a medication and the doctor says, see you in 6 months. Let's see how it went. Let's see how it went, right? This whole thing with obesity is a really complicated path to go through for many reasons. So, accompanying for me is more like what you're saying, right? It's not a day-to-day relationship, but maybe something much more continuous with support from different professionals who cover different areas, nutrition, psychology. That's what it means to accompany, but not just prescribe a medication and forget about it, right?
That's what we do with Yasem, right? Because there are many people who can prescribe you a medication, but we really make sure that everything the patient needs is addressed and we have continuous follow-up. I mean, if you haven't written to me in 2 months, what happened? What happened to you?
So,
Our system sends a warning, hey, this patient hasn't messaged you, so I'll reach out to them. If they don't contact me for 2 more months, I call them. Let's help them.
well, that's it. We thank you, Christian, for helping patients with obesity, which is a huge health problem, and I hope you keep doing it for a long time with a lot of enthusiasm and motivation, right?
Thank you, Borja. I loved visiting Malaga and appreciate the invitation.
That's right. Enjoy Malaga. Thank you. And here's another episode of Better Than Yesterday. You already know, this episode is sponsored by Yasem. You have all the information about Yasem in the description and in the pinned comment. If you want more information or need to know more about how it works, and also, for following this channel, you'll get up to 70% off your first month of treatment. So, I'll leave all the information down here. Thank you very much for watching this episode, and thank you so much for subscribing to the channel. See you in the next one. A big hug, and let's keep empowering each other.